So I examined the anatomy of the dorsal scapular nerve and the relationship that it has with the long thoracic nerve. Okay, we'll start with a brief review of anatomy, starting with the dorsal scapular nerve. It arises from the C5 spinal nerve origin, going through the middle scalene muscle or piercing the middle scalene muscle, then innervating the levator scapulae, and then traveling posterior to the back to innervate the rhomboid major and minor muscles. Next to it, also arising from C5, is the long thoracic nerve, which also has spinal nerve origins from C6 and C7, which you cannot see in this photo. But those sometimes will pierce or non-pierce through the scalene muscles and go anterolaterally along your rib cage to innervate the serratus anterior muscle. This muscle is important as it's in charge of keeping your scapula attached to your rib cage. And just a little bit of background about this photo. This is actually one of the cadavers that I took a picture of during my study and dissected. So also just to briefly review the scalene muscles, as we're going to talk about these a lot in my results section, there's anterior, middle, and posterior scalene that attach to the ribs. And these are all highly involved with the dorsal scapular nerve and the long thoracic nerve, as well as other vasculature in the area. And if there's piercing variants and whatnot, this can cause problems. So dorsal scapular nerve neuropathy, common injury, usually due to entrapment of this nerve through the scalene muscles. This can cause some non-specific pain, which is very problematic for clinicians as it's very difficult to diagnose and is often misdiagnosed. Also, scapular weaning can occur usually from a long thoracic nerve injury, but there have been several case studies reporting only dorsal scapular nerve injury as the cause. And this right here is a cause, it is a wing scapula. You can also injure the dorsal scapular nerve from an interscalene nerve block. So injecting within that scalene region can damage that dorsal scapular or long thoracic nerve that runs in that region. Also, the Eden-Lange procedure is a surgical procedure that involves removing these levator scapula and then rhomboid muscles off of this medial border of the scapula. So you can imagine, you can see how close the dorsal scapular nerve is in that region. So if you cut too far over, you can actually damage this nerve. So our study's goal was to further characterize the dorsal scapular nerve and then also to find connections with the long thoracic nerve. And this can give us insights into clinical manifestations and also for safer surgical procedures. Moving on to the methods here of my study, starting with the specimens, we had 32 donors in this study, which gave us 64 sides since we did this bilaterally. They were formalin embalmed, and the initial dissection was done by first-year medical students as part of their gross anatomy lab. And of course, if anything was damaged, any nerve or muscles that we needed for our study, we went ahead and excluded that from our data set. So during dissection, we took a lateral approach while the cadavers were in supine position to find the dorsal scapular nerve here and the long thoracic nerve. And we were able to take measurements from this position. And then once we were done with that position, we flipped them into prone here, and we were able to visualize dorsal scapular nerve as it travels down the rhomboid muscle here. Took many measurements during this study, some categorical, some numerical, those using digital calipers for numerical measurements. I want to detail two of them in particular with you of our numerical measurements. So this was to find the vertical distance from where the dorsal scapular nerve pierced through the scalene muscles here, and that distance it was to the mastoid process. So that's what I said earlier, trying to find a vertical place of where that appears in the neck. Also, we found the distance of the dorsal scapular nerve from the medial border of the scapula. So the medial border of the scapula is in black here, and we found that at two zones. Zone 1, which was at the level of the scapular spine, noted by this distance here, which is blue, and zone 2, which was the midpoint between the scapular spine and inferior angle of the scapula. So as I present my results, my numerical data will be in mean and standard deviation in millimeters, and our categorical data will be shown as percentages. And our associations are independent two-tailed t-test, as well as one regression analysis. Many pictures are going to come up shortly. All of the black arrows are our dorsal scapular nerve, the blue arrows are a long thoracic nerve, and a star will be a connection between these two nerves. So in our study, we found classical anatomy of the dorsal scapular nerve about 87% of the time, which is originating from C5. But we do have some notable exceptions here. On your left, you'll see C5 here, along with a small little C6 connecting branch that connects within the scalene muscle here, forming the dorsal scapular nerve. We also had a C5 one, where the dorsal scapular nerve was only formed by the C4 spinal nerve with no C5 component. And then on your right, which is actually personally my favorite dissection of this study, is a C4 coming from here, and then a C5 component traveling between the scalene muscle, connecting to form the dorsal scapular nerve here. This one actually has a connection with the long thoracic nerve, and we'll detail that a little bit further. So the dorsal scapular nerve, like I mentioned earlier, normally pierces the middle scalene, which we saw about 75% of the time in our study. So we also classified these into non-piercing and piercing variants if they were different from this. So our first non-piercing variant I wanted to show was anterior to the middle scalene, which went between the anterior scalene and middle scalene. Another non-piercing variant, this dorsal scapular nerve actually went posterior to the middle scalene, between the middle scalene and posterior scalene. And then a piercing variation here on the right is the dorsal scapular nerve piercing the posterior scalene. So some clinical associations with the piercing pattern of the scalenes. There has been OMT that has treated a hypertonic or an inflamed scalene muscle for the treatment of thoracic outlet syndrome, but it has not been shown to, or no one has looked at it in treating dorsal scapular nerve entrapment. So we theorize that if you could use OMT to treat the scalene muscles, which is a common point of entrapment, they could possibly provide relief for symptoms of DSN entrapment. So going to that vertical distance of where the dorsal scapular nerve appears out of the scalene muscles in relation to the massoid process, we found that males had a greater distance than females, but we went a step further to see if height predicted this distance, and we found that height actually did not predict this distance. So correlating this clinically, we think that clinicians should be aware of sex-related differences when performing injections or procedures within this region. So now looking at the relationship between the dorsal scapular nerve and long thoracic nerve, we found that of the 46 sides included, over 65% of them displayed a connection with the long thoracic nerve. So we looked a little bit further then to look at the long thoracic nerve piercing morphology. And long thoracic nerves that pierced any scalene muscle, 82% of the time it had a connection with the long thoracic nerve, whereas long thoracic nerves that were non-piercing only had a connection 33% of the time with the dorsal scapular nerve. Here are three examples of the relationship between these two nerves. Here's a common C5 origin that bifurcates here into the dorsal scapular nerve, and then a connecting branch here with the long thoracic nerve. Here's that picture again of the dual origin of C4 and C5 forming the dorsal scapular nerve. But then here's a connecting branch with the C5 component of the long thoracic nerve here. And then on your right, you'll see the dorsal scapular nerve here on the left and the long thoracic nerve on your right, running in parallel, forming a connecting branch here. Here's another connecting branch between these two nerves that I wanted to show. But correlating this clinically, the prevalence of these connections between the two nerves may explain scapular winging in the setting of dorsal scapular nerve entrapment or in the absence of long thoracic nerve injury. Moving on to where the dorsal scapular nerve is in relation to the medial border of the scapula, the dorsal scapular nerve becomes further away from the scapula as it descends down the rhomboid muscles. So correlating this back to the Eden-Lange procedure, as long as the surgeons stay as close as possible to that bony insertion point, they should avoid damage to the dorsal scapular nerve. And just to point out, none of our nerves or dorsal scapular nerves crossed that bony border, and our smallest distance that we recorded was 5.8 millimeters. And our last association here, we looked at this same distance, but with dorsal scapular nerves that had a long thoracic nerve connection and those that did not. And those that did have a connection seemed to stay closer to the medial border of the scapula compared to those that did not. So this can possibly give us insight how connections between these two nerves may change it morphologically as it travels distally. So in the future, we think that clinicians should be aware of the variability of the dorsal scapular nerve and be able to recognize the connections that it may have with other nerves, as this could possibly let us know about certain clinical manifestations. And of course, there are still limited studies on the topic of the connections between these two nerves, and we call for future research to be done on this subject. And of any study, there's limitations, and especially in cadaveric studies, muscles and nerves are known to shrink as they dry. So this could have possibly altered our numerical data, but we still think the trends that were recorded are valuable. And of course, the categorical data that we collected in the study should not have been affected by that. And certain data associations that we had a small sample size, so future research could, of course, help find different correlations. And to end, I'd like to thank those that gifted their bodies through our Gift Body program. It allowed me to learn as during my first year and do research to help benefit future patients, and I'm incredibly grateful for that. And also, I want to thank Ken Bradford for keeping the anatomy lab always clean, allowing me to focus on my research and my learning.